All right, welcome everyone. For those of you who don't know me, my name is Amanda Demmer, and I'm the Learning Specialist and Programs Coordinator for Community-Based Research Canada, and I'll be the moderator for today's session. We're really excited. Today is our second session in a new series that we premiered last month on community-based research responding to crises. And specifically the first four events within this series, we're looking at this sub-theme of community-based research as it can respond to health, wellness, and social inequity. So a very exciting and relevant topic today, looking at how we can center community when we're doing health system innovation in a poly-crisis age. So very relevant to today's society and the way that we respond to crises. We have a fantastic team today, Ginetta, Salvalaggio and Veronica Varewny presenting. Shanell Twain unfortunately had to step down from the presentation today, but was a pivotal part in preparing for the event. This presentation, of course, our e-learning series is brought to you by Community-Based Research Canada. We recognize and acknowledge that the CBR Secretariat is situated on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. If you're unfamiliar with CBR Canada, we are a membership-based organization with a mission to advance community-based research excellence in Canada by strengthening partnerships, building capacity, mobilizing knowledge, and championing community-based research. We are a social enterprise. We are funded by our membership base of over 70 organizational members, as well as individual members across Canada and beyond. And as part of our programs that we provide to members, we host events like these e-learning events, our webinars, as well as a bi-monthly community of practice. You can find more information on our upcoming events, other events we have, as well as event recordings of past events on our website. And my colleague Rose is going to share the link to our website with you all now in the chat. In the spirit of reconciliation, we open each of our e-learning events by reflecting on and amplifying the goals of the Truth and Reconciliation Commission's call to action. So each month they choose one of the calls to action that seems relevant to the topic. And this month, I've chosen call to action number 18. So we call upon the federal, provincial, territorial, and Aboriginal governments to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian governmental policies, including residential schools, and to recognize and implement the healthcare rights of Aboriginal people as identified in international law, constitutional law, and under the treaties. So we're committed to continual reflection on the interconnections between truth and reconciliation and the various topics we approach using community-based research. And as we look at, in these couple series, we look at health and health inequities, very relevant to reflect on how there's an interconnectedness between inequity and Indigenous health in Canada and the role that colonial policies in Canada have had to play in that. So today's e-learning event, after I'm done my brief opening spiel here, I'll pass things over to our presenters to give the presentation today. After the presentation, we'll have about 20 minutes, hopefully, for question and answer time. So this is your time to ask your questions of the presenters. We encourage you to type questions in the chat at any time during the presentation. When I get to the question and answer period, I'll scroll through that chat box and see if any questions have come in, and we'll start with those. So that can help get the question and answer period rolling a little more quickly. It can also help ensure we have time to get to your questions, since we don't always have time to get to them all. So please, if questions come to your mind during the presentation, enter them in the chat box at any time, and we'll get to them when we begin the facilitated question and answer period. We do ask that all participants keep their microphones muted during the presentation, just to reduce any background noise. You're very welcome to have your cameras on if you'd like. It always helps instead of presenting to a blank screen. And particularly when we get to that question and answer period, it can be nice to see the faces of folks. You may have gotten the notification already that our event today is being recorded. It will be available on our website for you to rewatch afterwards or to share with others. We try to reach as many people possible with these events, and that also means sharing the event recordings out with folks who weren't able to join us in person today. So that will be available for you on our website after the event. So without further ado, I will introduce and pass things over to our presenters. Our presenters today are coming to us from the Inner City Health and Wellness Program out of the University of Alberta. Um, so we have with us Dr. Salvalaggio. Ginetta is a professor with the University of Alberta Department of Family Medicine and an associate scientific director with the Inner City Health and Wellness Program. She holds a Master of Science in Population Health and a medical degree from the University of Alberta. She completed a family practice residency in Thunder Bay before returning to Edmonton to establish a family practice and begin working with the University of Alberta. Shanell was unable to join us today, but we are very fortunate to have Ronnie joining us in Shanell's place. So Ronnie is a student and research assistant with the Inner City Health and Wellness Program that has worked directly with the study we'll be hearing about within this presentation today. They're also a member of the Alberta Alliance who educate and advocate responsibly and has been involved in community outreach activities since joining this organization in 2022. So I will, with great thanks and honor, pass things over to our presenters, Ginetta and Ronnie. Thank you so much.
Thank you so much. Tanse, hello, bonjour, from Amisquichy Waskaikan, which is the Nahia word for Edmonton. You can go ahead to the next slide. And apologies from Shanell that she could not make it this morning, feeling under the weather, but I trust that Ronnie is going to do justice to the specific project that we're going to be talking about this morning. I'm going to do a bit of the front end work and then hand it over to Ronnie. Our territorial acknowledgement is on your screen. We live and work in Amisquichy Waskaikan, which is the Beaver Hills House, the literal translation of the original name for Edmonton, located within the northern prairies of Turtle Island, the original name for North America. For thousands of years, this has been and continues to be a common territory to many peoples, including the Cree, Sioux, Stoney, Dene, Métis, Blackfoot, and many more. This place is also called Métis Nation of Alberta Region Number 4 and Treaty 6 territory. I also just want to situate who I am. I am a cis hetero, able-bodied, European descent settler. I speak both of our official languages fluently. I often find myself in the center of the wheel of privilege and power, especially as a physician and an academic. And I recognize that, and I feel that it is my job in that space to um, disrupt the wheel of power and privilege and ensure that I'm connecting as much with people throughout that wheel as possible and creating equitable space for everyone. I'm going to let Ronnie say a few additional words for herself, and then we'll move right on.
Hi, I'm Ronnie. Thank you for the warm introduction. I am also from Edmonton. I'm first generation Canadian. Both my parents immigrated from China and Poland. And so I kind of find myself in dancing between the middle and the outside of the ring. Yeah, and I also acknowledge that we are on Treaty 6 territory. We are in Beaver Hills House. Yeah, thank you.
Awesome. Next slide, please. So Shanell and I kind of created this front end together, and we wanted to share a little bit of a journey of where we've been as a group. This is a bit of a somewhere around 20-year story together. Our work is largely centered around people in central Edmonton who use drugs. People who use drugs well before our current drug poisoning crisis figured prominently in the news cycle over the last several years. This is a long-standing issue that people who use drugs are underserved by conventional health services. So we tend to focus on just a specific single issue at hand, tends to be oriented around very specific kind of crisis. What do we need to do right now? And then forget about kind of the context and the nuance of people's lives. And then there's, of course, a lot of barriers to healthcare access. So this was the space I was entering into when I was much earlier in my overall career, both academic and medical. Next slide, please. people who use drugs are also underserved by conventional planning and design and research, frankly. So they are underrepresented in data and or misrepresented. We tend to rely completely on just administrative data sets and not on just chatting with people and finding out their stories. So there tends to be a lot of extrapolation of what works in the general population setting as well, and just plunk it and move it over into a very specific group of people with very specific perspectives and values and goals for their care. They tend to not be involved when it comes to patient engagement initiatives, when it comes to knowledge mobilization initiatives. And also, people who use drugs have been burned over and over and over again for many, many decades, where we get these really good ideas for pilot interventions and then they get defunded. And so it isn't just what we heard loud and clear as a society with the Royal Commission on Aboriginal Peoples, but it's it's fly in and fly out helicopter research, but also fly in, fly out interventions within the healthcare system as well. So next step, please, or next slide, please. And so we recognize that sometimes healthcare and also healthcare actors therein, so that includes people like myself who are health services researchers, we can create harm. And so we can create harm in a few different ways. Sometimes when we create policies within our spaces that are inflexible, that don't reflect people's unique circumstances and don't actually meet their specific priorities and goals for care, you can end up with, that square peg in a round hole, very poor fit for whatever intervention is offered. There's not a whole lot of options there that are actually workable or feasible for people. And so bad healthcare things happen. People leave early, they don't get the care they actually need because we haven't tailored the care. Incidental, in addition to that, we also create, and this rings, if you look at, there's some theory on the right, the candidacy model that Mary Dixon Woods and colleagues had advanced, where we typically set up a whole lot of hoops and barriers and specifically for people within the margins, for people who are already experiencing barriers to care, we tend to set up additional cares to try to get people to prove their deservingness of care and their deservingness of accessing services. So this is the context in which I wanted to work with community to build back better. Next slide, please. So within the Inner City Health and Wellness Program, we wanted to take an action orientation. We wanted things to be very community oriented, community centered with respect to the outcomes that we wanted to measure, with respect to the questions that we wanted to ask and answer. Excuse me. We wanted to push back against the dominant approach of top-down implementation, and start looking at ground-up solutions, and really take that nothing about us without us seriously. Next slide, please. So within the Inner City Health and Wellness Program, and I'm certainly not the only founder, but there was multiple of us, and along the way, and I won't get into everybody who is part of that journey. We are that journey's a little bit on just a little bit on our website, but our guiding principles are that we will take direction from the needs of the community that we serve. Activities are driven by philosophies of reducing harm, and respect, and empowering people to make whatever healthy choices, and letting people define what health looks like. The team and its activities will be culturally competent and will focus on relationship building and trust. This one is incredibly important to me. And then that we take that broad definition of health, as I mentioned before, and that we really use action orientation in whatever we do. On the right is just some folks who were kind of the OGs of our community advisory group who helped us set up the program. Next slide, please. And actually, that's Shanell actually on the right in the picture, and she's been at this from the get-go when we developed the program. So how were community members initially involved? So we had community liaisons, and Shanell was one of them. really getting the word out in the community, sharing information with our team, though, just kind of letting us know what's going on in the community and what we need to be responsive to, helping us with coordination of our community advisory group, and teaching us a lot about what data collection should look like, what recruitment and retention and so on for studies might look like. And then the group helped us with identifying the right types of people who to hire into programs and help train people up, both people with lived and non-lived experience. They've helped us with troubleshooting program and study designs. They've helped us with data interpretation, of course, and then knowledge mobilization. Next slide, please. So our early work, we really we had a window of opportunity to try to improve healthcare services at our central Edmonton hospital, and created a complex health team intervention, really looking at wraparound substance use care, but also from a very much a social determinants of health lens. It was a multidisciplinary team. I was involved in the evaluation of this. If you want more information about that, it's available there. But we did have community liaisons and community advisory group involved in steering that entire evaluation. Next slide, please. In the middle of that evaluation, so just to contextualize, it was 2014 to 2016, and guess what happened in Western Canada over that time frame? Things changed for community big time. What we did find in the course of that evaluation is that there's only so much that the hospital can do when we're dealing with a bunch of community constraints. First of all, we were dealing with a bit of like a relative primary care crisis already at that time, lack of access for community. We were looking at an emerging housing crisis, lack of access to housing in a reasonable time frame, a bunch of unmet need for counseling and support. But the key thing that happened over that time period is we also noticed a major uptick in drug poisonings. Next slide, please. So it meant all of a sudden that the questions and the priorities for community changed very rapidly. And so we went from evaluating these health services in a very conventional way and looking at kind of longer term how to support the community through to, okay, what do we need to understand right now? And so there are some other things that we started to study together. How do you provide supports out of the emergency department when people start showing up? How do you support transitions so that they're better going back to the community? How do you improve social care through all of this? Then a pandemic hit and the crisis got even worse. And how do you deal with how do you provide care when the system is strained to the max? And also, how are you caring for the caregivers? So we started exploring all of these areas together. Next slide, please. We started rethinking what is knowledge mobilization, what does that look like? This is one example that Shanell wanted us to highlight. We found a bit of money to pull together what ostensibly was meant for communities. So it's a community written book on dealing with all of those social determinants of health, like what do you do as far as ID, income, so on, all of these sorts of things that were concurrent issues for people. And it turns out it's actually very educational for me as well, rethinking how we actually talk about this stuff and what kind of resources are available. So this was written by community, and it's way more accessible than any other resources around social intervention that I've come across. So that's some of the other work that we did. It wasn't just like rote research, but it was also some of this KT type work. Next slide, please. And so how are community members involved now? So it was a bit of an evolution over time. So with built capacity, community researchers are fully integrated into the team now, because we've been able to, increase our infrastructure, but also increase the size of our team. On the left hand, you see some of the team members from a 2023 quantitative survey that we did in central Edmonton, and chatting with people who use drugs and their emerging health-related needs since the pandemic. And you'll see grad students, community research, summer medical students all working together here in this photo, and learning from each other through protocol development, data collection, analysis, and KT. So just working through the entire project together, and they're still very much involved. I will just name them here: Zoe, David, Bethany, and Campion. Fantastic team. You'll see the branding too. They were out at a community fair. Absolutely tried to get out and do some of these community events wherever we could. On the right, you'll see the early stages of new work, or of the team, the core team involved in early stages of some new work to support Indigenous people who use drugs in helper roles. You could argue everybody in community is a helper. So we're going to have a very big tent thinking about this, but community researchers here are co-authors and co-applicants on the grants and the outputs, and the academics are essentially there to support. So you'll see Tracy Wilson, our knowledge keeper, myself, Adrian Earl Robinson, Vanessa Gladue, and then Renee, a postdoc, who incidentally, Renee is also involved in the work that we are about to, the study that we're about to discuss in greater detail today. Next slide. So I'll hand it over now to Ronnie to tell us a little bit about this one study that we thought really mattered and really exemplified how we do our work. We really want to talk about how we do our work. Over to you.
Thank you so much. Welcome to the Unsurvey. So this is, we enter an era of a polycrisis where a community is facing multiple threats to its well-being, from infectious diseases to a toxic drug supply and to a housing and a climate crisis. So how do we, as a research program, give voice to community in a way that allows community to share their truths and imagine a way forward? How can we create preconditions needed for our co-design solutions to be heard? So the practice of research in polycrisis spaces emphasize elements on reciprocity, safety, respect, and celebration, which I'll go further into later. Our core team is made up of community members, academics, nonprofits, knowledge users, and trainees, and we all make up different parts of the pie. We all co-develop the process and that build safety and respect into the interview process, which I'll also go further into later. This is a qualitative study that uses two main methods. The first one is that we gather community voices in the form of micronarratives, which really allows the space for people to say what they would like to say without having to put it into A, B, C, or D. That's why we call it the Unsurvey, because it's not really a survey. And the second thing is also we have an arts-based asset mapping and collaging. Picture is worth 1,000 words. So yeah, next slide, please. So this is data collection. I'll introduce the team. So that's me on the left. And then we have Les, who is a major pillar in the community. He has been around, he knows everyone. You can't walk down the street without him being stopped. And so you can imagine the trust that we have when Les is sitting in the interview room. In the middle, we have Colton. He's one of the med students. He also has experience in shelters in BC. Not pictured is Cindy, who is also a med student. And yeah, she's been a pleasure to have on the team too. And then following that is Bethany and Asha, both of which are members of AWARE and both very active in the community. And Bethany was also mentioned earlier from the previous research project. So since we are peer researchers who co-developed the process and we have built trust with the community, we have created an environment that allows a space to ask people, how do you care for yourself and others? And then we give the floor to the experts to share their story. We, the researchers, write down what they're saying exactly, and then we review it with them afterwards. I'm like, okay, can I read your story back to you? And then we go through it again and they're like, yes, sounds great. Or actually, no, take out this part, move this, So it's really their voice that we get to authentically record, give respect to their name, and then we also, and then they get to interpret their story afterwards. They get to self-categorize it. So after we ask them to share their story, we ask, give give a title to your story. What is your story about? What was threatened? We ask more questions like where were sources of support, and in an imagine better future, what would have been different? And that imagine better future question is more strength based, which we also carry that theme of like strength based assets later on. While waiting for the sense making interview, we have an optional portion that is semi public where we ask people what's in your bundle. This is Sarah Auger, who also was later pictured. And she's the one that brought us that question. She said, well, why don't you ask people, like, because we were trying to ask people, how do you stay strong? How do you stay grounded? And she was like, well, why don't you ask people what's in their bundle? Because, you know, medicine people used to carry around their medicine bundles. And so what would be in there? And that's when the researcher writes down some of the assets that people tell us, and then the participant then also self-categorizes their asset onto our asset mapping chart, which also later pictured. After that, we also offer collages. We make collages with old magazines, and that adds another avenue of self-expression where people get to we get to experience someone's story. And then we also people can take their collages with them as well. Next slide, please. Cool. And so on the left here, you have the triad, and on the right, you have the asset map. So the question I asked earlier was, in your story, what was threatened? And so on the left there, you can see the way people answer that is that they move their dot according to the triad. And so you can see at the top it says safety, on the left it says trust, and on the right it says health and wellness. And I mean, I feel like the data kind of speaks for itself of where people feel that they can receive the most support or not. And then on the right, we have the asset map. All the categories were co-developed by the whole team, and you can see where people have put their assets, which is just really nice. And this is the mobile version, so it's flat, but we do have one that goes on the wall behind us. And so it really turns into a bar chart, which is just really awesome to see come together. We also do team meeting check-ins where we explore patterns and from like self-interpretation. This is a qualitative process that is facilitated by the software, the sense-making software, and all team members contribute. Awesome. Next slide, please. These are some stories from interviews. There are 187 and counting. Data collection is still ongoing. Through storytelling, we are able to gain a deeper understanding of current experiences to envision future service provision collectively. Our analysis is ongoing, but key themes that we have seen is the importance of intersectionally tailored supports, like intersectionally tailored housing supports informed by lived experience. Love is a basis for community. Love is a basis of safety in community. And there are concerns about policing and decampments. And also there is stigma in accessing healthcare and a challenge to responding to increasing psychosis. So yeah, these are some of the key things and gaps that we've noticed. Next slide, please. So this is collective safety. So here we have Bethany and Les. There are some kind of features to safety here, which I'll point out. So first of all, we have the two of them paired together, which is in case if there's emergency, but no one is ever alone. So then you can work together as a team. Bethany is also filling out the safety log, which is something we do every day, every morning on the floor. And then we also have Les with the iPad, which is how we take our survey. And also around them, you can see that there's food, and they are on the Streetworks van, aka the ambulance. It's fully loaded. And then on the right, there is an image of the blank asset map before people have put their assets onto it. And around that, you can see that there is medicine and tobacco, naloxone kits, art supplies, and and good vibes. It's really beautiful to see everyone kind of come around and be like, what's going on? And then you kind of give them a brief, like, what keeps you strong? What's in your bundle? And then people just start grabbing the paper and putting it down. It's really beautiful. All right, next slide, please. And this is celebration. It's really important to stop and celebrate as this is ongoing, and also just every milestone. This right here is the poster from the art symposium. We won the poster. It wasn't like a competition, was
No,
it? But
it was a poster award.
it was
Yeah.
a poster award. Yeah.
Yep.
That was really awesome. I believe it was in innovation, impact, and creativity, and something else. But on the left there, left of the poster, you can see the bar chart that I've been mentioning. And then on the right side, we have more assets, but then also the collages that people have made. Also, you see Sarah Auger from the left, and then you can kind of see me tucked behind there. I think in the middle is Elaine. On the right is Asha. And then on the very right is Les. Another thing too, one of the stories that is featured on the poster and also featured on the previous slide, I ran into the community member who told us that story, and I showed them the poster, and we had a beautiful little celebration together. Yeah, it's the divine intervention, and uh, it was a really touching moment to actually be able to share the celebration with them. So immensely proud of them, and they were so immensely proud of us too. And I was like, stop, this is yours. These are your words. We are simply just the microphone here. So yeah, celebration, very important. Got to share the love. And yeah, thank you so much.
Yeah, so just to wrap, I'm just coming back to big picture, and thank you so much, Ronnie, for doing the whole study justice as you just did. So these are some thoughts that Shanell crafted many moons ago, but they still apply here. And so we just wanted to share some thoughts that we have about what matters to community partners. And perhaps some of this resonates with some of you who are listening in. We are already here. So by we here, I'm talking about community. We are already here in community doing the work. That must be acknowledged. Academics need to understand that. Involving more than one of us, very, very important. We need steadfast, committed champions, so allies, people who are from outside a community. Partnership is important, but be there, be steadfast, be committed, invest time in the relationship, visit us in our space. We need to trust you. Follow through is critical. So do not fly in, fly back out. Leverage those existing resources and don't reinvent the wheel. Do not create your own community from scratch. That's not how it works. And think about what community assets and strengths there are already. We often operate within health services from a deficit base, and I think we have to get away from that. Using plain language is really important. Stop and ask yourself, like in advance and real time as well, is this something that my own grandmother couldn't decipher? How if we use my grandmother as as a non-English speaker, like, does this make sense to my Nona? If it doesn't, then let me back up. Recognize the importance of gathering together and celebrating, and recognize our investment, like what the community gives, and remunerate properly, remunerate us. Next slide, please. This is some work that we have also done around how to create health and well-being and avoid harm for people who use drugs, who choose to engage within the health system, including within researcher roles. So putting yourself out there as a community member comes with reward, but also potential risk if it's done poorly. So we did a realist review looking at this space about how we can maintain health and well-being for people who choose to be partners. And a couple of big themes, takeaways for you to think about is that this work can be incredibly transformative. It can, transform identities, create social connection, can help with people's strong desire to give back and to care. Um, but if some of those conditions are absent, it can create some harm for people, some harmful health outcomes. It also needs to come with meaningful support. So what are we doing as researchers, for example, in ensuring that we are removing we are being actively anti-racist, anti-oppressive, removing stigma and discrimination within our spaces? Are we providing psychological support, occupational support, reducing occupational risk, and are we compensating adequately? So those are some salient examples of how we can create meaningful support for people. Next slide, please. There's also quite a bit been written about this as far as resources, handy resources for working with people who use drugs. I'm just sharing some screenshots of some really good best practice documents that are also out there that have certainly informed my work and our team's work. I encourage you to have a look at those at a later date. They're pretty accessible online. Next slide, please. And ultimately, I just wanted to finish my celebrating of this team, just showing you how large it's become and how interdisciplinary it's become. And within this team, literally here on my back porch, community members are embedded throughout this photograph. And that brings me an incredible amount of joy. So I just wanted to talk about relationship as harm reduction and as a way forward, and that we continue to espouse as a team. I just have the one thank you slide at the end, but just want to acknowledge that we have some funding that has allowed us to do the current study work, but also to get us to where we are today, and also some tremendous in-kind support from some of the organizations up top. Thank you so much. Some more photos on the left of some of our original community advisory group members. I will honor, many of them have passed, and I just want to bear witness to that. But really, really grateful to how they've shaped our team and our thinking and our praxis. Thanks. Happy to take questions.
Thank you.
Thank you so much, Ginetta and Ronnie. It's so fabulous to hear both, kind of the philosophies and the process of how you do your work, but also what some of the outcomes and the impacts have been, and then some of the more technical aspects of how you did data collection and how you really did it in a way that was innovative and allowed for that self-expression and the fidelity to community voices. It's really neat to see, you turning research process into something that was a community celebration, a community event, something that brought the community together. And, Ronnie, you spoke about people getting excited and wanting to be engaged in terms of answering that question of what fills their bundle. And, when we embed those kind of opportunities for community to come together and meaningfully engage within a research process, it can be so beautiful. So thank you both for sharing more details on that. And just, to acknowledge on behalf of CBR Canada as well, the Inner City Health and Wellness Program Research Partnership was the honorary mention, the kind of runner-up for last year's award for excellence in community campus research partnership. And I'm sure you can see why after this presentation, how strong of a community campus research partnership this is, and why it was, very, very deserving of an honorary mention, if not more, from our awards program. So thank you. And we'll open the floor to questions now. So I'll stop my screen share here. And I very much encourage, anyone who has questions, feel free to type your questions in the chat box, and we'll monitor that chat and we will ask any questions that come in. So take some time to think. I don't see any that have come in so far. So please enter your questions in the chat. We'll get through as many as we can. And perhaps I'll start us off. There's something that I've been thinking about in kind of tying this e-learning event into our most recent community of practice for anyone who attended that event as well. So our last recent our community of practice last week, we talked about this idea of, how do you engage community and community organizations and nonprofits in a time of crisis when there is a lack of capacity, a lack of resource. Often, community organizations are um, under resourced to even run their own programs, never mind try to participate in research alongside that. And you mentioned in your presentation reciprocity as something that was very core in your research. So I'm wondering if you can kind of speak to how you lived that value of reciprocity when you engaged with community organizations, given that you've spoken about this health crisis that the organizations were involved in. So what did that look like, trying to get that engagement from community partners in that context?
Okay. So I would say that, yeah, and we all we all did the
Mhm,
pandemic pivot, so that's a very good example of trying to reevaluate where we're at. I think being gentle with ourselves and also just taking a step back and figuring out what does everybody within an established partnership
mhm,
need in this moment? What will help us and serve us in this moment? And it turns out
mhm,
that some research was still necessary and still a priority, right? Um, we, for example, pivoted to some policy analysis work, um, just, highlighting perhaps some of the gaps, but also some of the opportunities that a constraint such as a pandemic um, introduces to us. So, but just starting to pay attention to what community feels is necessary in the moment. Um,
mhm,
as opposed to trying to ram through things that perhaps no longer fit or need to be paused. So I
mhm,
think what that requires is constant relationship,
mhm,
and really, really attuning to what is um, just because you have some agreement a priori or established from a year ago or 6 months ago. It's an iterative process and are always checking in and saying, are we still on the right path? So I think that's really, really
mhm,
important. But recognizing that you don't all of a sudden just assume that everyone is constrained and doesn't want to do things, because I think often people do want to get involved. We have many people within the community advisory group who are just wondering, hey, when are we going to do this thing or when are we going to do that thing? And often the questions come from them is like, I want to, a classic one for me recently has been, I want to do some work around methamphetamine. I want us to advance this work. So paying attention to that and not assuming that people do not have capacity.
mhm,
I do see our role as in within academia of hustling and finding the means, finding the infrastructure and the supports needed to actually make things happen that the community wants to see happen.
mhm,
And just being really constantly attending to that and figuring out what resources can I bring in, highlighting and flagging those for people. So that's my
mhm,
role. But the reciprocity there's this constant wanting to give within community, wanting to
mhm,
share, wanting to co-design, wanting to build back better, and not wanting to be excluded, even if we are facing multiple constraints, not assuming that that means
mhm,
we choose not to get involved.
mhm,
Ronnie, do you want to add anything to that?
Yeah, I do want to just add, specifically like with community when we're doing interviews, consent is an ongoing process. We're regularly checking in with people if they're hungry or tired, if they'd like to stop. Um, that's really critical to this, making sure that no one
mhm,
feels trapped in doing all of this. Um, we also offer food right away. Can't really think very clearly sometimes if you're hungry, so we try our best to fill their needs as we can. And then also offering medicine, cigarettes, tobacco, smudge, cedar, like sweetgrass, any medicines that we have on hand. Yeah.
Yeah, that's really great to hear kind of on both of those levels. Like Ronnie, you spoke kind of on that individual level there, and Ginetta, you were speaking to that kind of bigger picture and knowing that there's consideration given to all of those levels in terms of what reciprocity looks like. So thank you. And Ginetta, I really like the way you were speaking about that. It's almost like a reframing of um, thinking about research and service to community, which research and academia is supposed to do, but we don't always live those values well. But you spoke really beautifully about what it can actually look like to live that value of doing research in service to community. And when we do hold that privilege of being part of an academic institution, how can we leverage that privilege to get these resources into the hands of community, but also how can we really listen and tune into those community needs and do the research that the community wants to see happen instead of trying to bring in our ideas and ask for engagement. And having those, it sounds like those predefined relationships where you have the strong connection with community prior to the crisis, prior to the engagement, helps to be able to have that listening. So thank you both for sharing that. I see we have a question here in the chat from Remy, someone joining the webinar from Saskatoon, where they're seeing unprecedented surge levels of homelessness, um, uh, and on the back of kind of rising substance use and harm as well. One appears to be fueling the other. So speaking about homelessness and the rising substance use and harm, what are your thoughts on these issues? What are potential ways to deal with them at the community level?
Thanks. Ronnie, are you comfortable taking this first?
Sure.
Go for it.
One appears to be showing other. Well, first of all, like being out there with your community, doing what you can as an individual to meet community and offer them like kindness, even if you can't go out there and buy someone some meals or anything like that, but just to offer someone a conversation and a smile really makes a difference in someone's day. You could be the first smile in someone's day, and that could be all what they need to keep going. Yeah, it's it's a tricky thing, the rise of substance use and houselessness. They end up going hand in hand because you're coping with one thing and you're suffering from another thing, and that is uh how it that's how it goes. Yeah.
I mean, it speaks to whole person care and and collective care, but whole person support. And I think there's a lot of very sometimes very harmful narratives predominant in Western Canada, and I see you're from Saskatoon. So I mean, I think very similar narratives around that there's something somehow problematic about um, uh, persistent encampments and so on. I think people forget how much care is within communities, within the unhoused. And I'm very mindful from an Indigenous lens and very, very good article from Jesse Thistle back in 2020 in CMAJ entitled Pekiwewen, which is a word for coming home. But this notion of homelessness and houselessness are very different. So this idea of being the people who are Indigenous on the prairies, unhoused, are never homeless. This is home. And you create home through community, right? You create home by caring for the people who are in the tent next to yours and making sure and looking out for each other. So that's something that I just wanted to build on what Ronnie had to say. And yes, this is poly crisis in a nutshell, is that you're dealing with housing and affordability and poisoning risk and so on. But people are trying to create safety for each other. I would love to see society create safety in a similar way and be intersectional in its offering of support, rather than assuming that all we need in this case is that everybody needs treatment alone without attending to all of these other issues. So I think there's the power of study and research to ensure that those community voices and perspectives are heard.
Yeah, it sounds like there's a lot of lessons to draw from, you know, the successes you've had in engaging with community and with people who use drugs in your study, and that could be relevant to also studying folks who might have that intersectionality of substance use or people who use drugs, as well as people who might be houselessness. And that distinction that you've brought up, you know, that difference between houselessness and homelessness, it's a way that we can kind of critically reframe the issue, I think, and that's a really interesting distinction. We actually have this ongoing series on responding to crises and how community-based research can be used as a tool. The last sub-theme in our theories, which will be the final 3 months of the series in April, May, and June, we're looking at the issue of houselessness as houselessness and poverty and intersectionality within those. So stay tuned in our series for more kind of ways that community-based research has touched that topic. Are there other questions that folks have? I haven't seen any others coming in the chat, but we have some time left if there's other questions that folks have. One of the things I guess that I'm really interested in, I think sometimes there is perceptions about community-based research when we're using these innovative methods that, you know, we have community engagement at the sacrifice of research rigor, which of course is very much untrue. We can do these innovative research methods while still upholding rigor in our research. And Ronnie, I think you spoke to that a little bit. You spoke to, you know, the ways that you analyze data and the ways that you use, there was a software involved in that. I'm wondering if there's any other ways you can expand on, you know, how you kind of balanced that need for research rigor with this need for having this great process you had in the research.
Definitely. There's definitely very important sides that the academics bring, and then also that the community members bring, and to really bridge that gap between academics and community, because if we brought our academic jargon into community member spaces, it would not really, we wouldn't be getting the questions answered. We wouldn't be meeting people where they're at, and that's the whole point of intersectionally tailored supports, is meeting people where they're at, and then to build with them, you know, so we're all working together and reaching the same goal. And so that's why we were working together. So we have the qualitative study, and then we use the sense-making software. It's open-ended, where we can still have our open-ended places for community to speak from, and then we also have it fit into the scientific method. And I think that's how we really like bridge that gap. Yeah, I feel like there's more I can say about that, but that's all that's coming to mind right now. It was really fun at the beginning to see the first draft of the interview questions versus the final draft that we created as a team, and it was a really nice transition to kind of get there. And also we worked with these ideas for a long time too, like yeah, all of us like going home thinking about it and coming back, and yeah, it was really good. And also just the amount of the community voices in this too.
Yeah, I would agree. I mean, it's an iterative process, and it's a lot of back and forth where, I mean, everything from the actual question and refining that question. I mean, there's going to be different people on the team who are going to have different roles in doing this, but then you know, you bring some literature review into that. And then you bring it back to the team and like, okay, how's the question look now? And then how are we going to design things, and starting to think about, you know, uses in similar communities, like what method might work here. You know, what might we use as tools for data collection and analysis that would work in this space, and why or why not. It's our job, some of us with more academic training, to kind of pull from some of that literature and figure out what has been used in these spaces, bring it back to the team, figure out what works. And then the data collection instrument, as Ronnie just spoke to, is again, I mean, I might have preconceived notions of what sort of how we might, like what specific things might go into our interview guide, and it got incredibly worked over. And that's a good thing because it's a better instrument that makes sense. We pilot test all of it with community members before we go live. So, and then right down to interpretation, as I'm sure you can imagine. So.
Yeah, you both spoke to something there that I think really underpins community-based research, is that it takes a lot of time in that development phase. It takes more time than, conventional research because of this iterative process.
Gee, that's a
But at the
really
end, you have that better product.
That's a really good point, Amanda, and that I encourage everybody who's writing grants to really factor in how much time this takes. This is not a lab full of, my former department chair used to say, you do not have a lab that involves just churning a bunch of rat mitochondria together.
Yeah.
It's got to be resourced differently, and the primary resource in doing this work is time. Money, yes, but also time, and building that into your plan and justifying it. And there's reams of ways to justify that in the literature, that these are the timelines needed for relationship building and for getting this right on an iterative basis. And so the cycle of a research grant, you have to take that into account for feasibility.
Thanks for speaking to that. Yeah, I think, we can speak kind of abstractly about all of these values and principles, and then it's a whole nother level to think about practicalities of doing this kind of work. And so thanks for touching on that briefly. We are, 5 minutes to the end of the presentation today, so we'll start to wrap up. And I'll get my screen share back up just for a couple last pieces as we wrap up today. So thank you once again so much for everyone for being here. As we bring our event to a close, just to remind you that you can view our past webinar recordings on our website. So you will be able to view this recording once we have it posted, as well as recordings of past events. So check those out. If you're interested, feel free to circulate this event recording with others in your network that weren't able to be here today that you think would be interested. And Rose has posted the link in the chat. We'd also love to stay in touch with all of you. So many of you are likely already on our e-news, our mailing list, which might be how you learned about this presentation. But if you're not and you'd like to stay up to date on future events that we're hosting, future e-learning events, future events in this series, you can sign up using the form that's been put in the chat there to our e-news. And we hope to see many of you joining us at the next event in the series as well. So as I'd mentioned, this series is running for the entire year. We run the academic year of September to June and take a break over the summer. So this whole year, we're tackling this idea of community-based research as a way to address and innovatively kind of create solutions during times of crises. So the first 4 events are all looking at crises of social inequities, health inequities, wellness, and things like this. The next event we have coming up actually involves some similar partners. Similarly, they're housed out of the University of Calgary, but I noticed the Boyle Street as one of the partners you mentioned, and that's one of the partners who'll be co-presenting next month as part of the Newcomer Research Network, presenting on some of their research. So more details, the event title and descriptions will be coming soon. You can stay tuned on our website and our social media channels for details, but we hope to see many of you back again. We'll be releasing details on this shortly, but we will also be hosting some kind of cumulative event at the end of this sub-theme, where we kind of try to find any threads or commonalities or themes that have stretched across 4 presentations that we will have had within this theme of community-based research responding to crises in health, wellness, and social inequity. So stay tuned for more details about that as well. So as we wrap up today, once again, thank you all for being here to listen, to participate, to take in the information. Thanks for the question, and thank you so much, both Ginetta and Ronnie, for being able to share this absolutely fantastic example of excellence in community-based research with us. So thank you. And hopefully we'll see many of you folks next month. Enjoy the rest of your day, everyone.